Welcome back to Therapeutics. In this block, we're going to talk a bit about dementias and the management of delirium. We're going to try to differentiate them and also look at indications, counterindications, and the impact of drug therapy both on contributing to dementias or delirium and also what drugs we may consider using for patients who have these conditions. So the epidemiology of dementias affecting about 4 to 5 million Americans, is strongly associated with advanced age. The most common types of dementia are Alzheimer's and Lewy body dementias, but not uncommonly we see vascular dementia, frontotemporal lobe dementias known as Pick's disease, and more often than not we see a mixed pattern, a mixed etiology of multiple factors contributing to dementia. Definitions of dementias, we consider ranges here, mild cognitive impairment, which is a transitional stage from the normal aging process to early dementia. Delirium, where there is a mental status change with a recent onset and lots of fluctuation. Typically, delirium presents with two of the following points: misinterpretation, illusions, or hallucinations, incoherent speech, disturbed sleep-wake cycle, and change in psychomotor activity. Usually when a patient has delirium, it's pretty pronounced. And in the acute care settings, we actually see delirium fairly frequently, often when the patient is under a lot of medical stress or is admitted to a different unit, particularly the ICU or his post-surgical or some other change in their status that contributes to the risk for delirium. Usually, a delirium is related to some stressor, medical illness, or medication that is added on board. Differentiating delirium from dementia, dementia is slower in onset, progressive, and typically irreversible. It's not considered a normal part of aging, and it progresses over a period of months and years. So when we think about mental status, we need to think about and changes in mental status, what's reversible versus what is not. And dementia is alcohol abuse, both in the short term change in mental status because of the intoxication with alcohol, but also long-term dementias associated with patients who have a long history of alcohol use is also a common scenario for patients with dementia. We also want to rule out normal pressure hydrocephalus. We look at thyroid status, so you're going to get thyroid function tests. You're going to look at electrolytes and fluid balance. A simple reversible status change is a vitamin B12 deficiency. Concurrent with many changes in mental status is depression. And when we think particularly of older patients, they have probably lots of reasons to have higher rates of depression associated with it. And then we look at the medications that are reversible causes, particularly antimuscarinic and anticholinergic drugs are notorious, opioids, corticosteroids, benzodiazepines, other sedative drugs, and some of the medicines we use for Parkinson's disease all have an impact on changes in mental status for patients. Here is a simple table that differentiates or talks about the differences in dementias and memory impairment. And comparing the standard dementias and memory impairment from Alzheimer's type disease on a number of different fronts. I encourage you to look at this. Keep in mind that when we always really will try to rule out all those reversible causes. So a patient who comes in with a mental status change, typically we're going to focus first on those reversible causes because there's something we can do about it. So B12 deficiency, thyroid status changes, depression as well. When we look at mental status changes, let's look now at some of the drug therapy that can predispose a patient to mental status change. And many times in practice, the simple answer for a change of mental status is look at the med list, look at what's changed, what's been added, what their status may have changed, and can we peel off some of the medicines that are associated with that a risk for change in mental status. So let's define some of the terms we use in mental status, which is a pretty broad, non-specific type of term. So altered mental status being a variable term, there are components we think of breaking down in the mental status. Is the patient arousable? Are they depressed or elevated arousal level? But also what's their cognitive status? They have mild impairment? Do they have moderate impairment with confusion, or severe impairment where they have amnesia or hallucinations? It's important for us to differentiate depression from delirium from dementia. And so we differentiate those in terms of onset, mood, their course, the patient's awareness of it, and how that impacts their day-to-day activities of daily living. And so all of these, I encourage you to sort of differentiate these. Typically with delirium, and it's much more acute, short onset change in mental status that the patient may or may not be aware of that change for them. And typically that has a severe impact on their life. Dementia, as time goes on and gets later, will also have impact on activities of daily living as well. So some of the non-drug causes that we think of in changes in mental status are listed in the next few slides. Let's first look at differentiating, is it a metabolic process, is it infectious disease nature, or what role does trauma have in delirium, dementia, or psychosis? Typically metabolic is a pretty common etiology for delirium, as are infectious disease states or changes in infectious disease. Also trauma. So one of these acute events in any of these realms predisposes your thinking this is delirium and not dementia. Typically dementia or psychosis don't have metabolic ID or traumatic influence. We also look at the central nervous system, and what you'll find for delirium is that there often is some acute change again, ischemic stroke, hemorrhagic CVA, hypertensive encephalopathy, tumor, something like that. Whereas in dementia, often it might be either multi-infarct or degenerative dementia. And for hypoperfusion, typically we think of delirium more so than dementia or psychosis. What are some of the drugs that are involved in mental status change? And it's important, at least in this curriculum, that we make sure you're aware of some of those, because when you get in practice, you need to kind of identify which agents are problematic, and particularly in older folks, but in any patient who has a change in mental status. So the classic drugs that we see in delirium that are problematic are the antimuscarinics or anticholinergics. But actually, any drug that has central nervous system properties to them could conceivably be associated with a delirium. So you want to look at, is there a new addition to the patient's regimen, or maybe a change in something else that affected the pharmacokinetic levels or pharmacodynamic approach to how that patient is responding to those medicines. But those are the common meds that we'd see seen with delirium. Dementia, not so much, although the antimuscarinics, anticholinergics sometimes can worsen pre-existing dementia, but we don't usually think of drugs as being quite as primary in their etiology as we see with delirium. So since the anticholinergics seem to pop up frequently, let's look at some of the data over the last couple of decades that have pointed to antimuscarinics or anticholinergics being problematic in changes in mental status. One of the things we think of here with anticholinergic risk is to rate the degree to which a drug binds to muscarinic receptors as an antagonist. And here's a study that was done over a decade ago that looked at quantifying that anticholinergic risk. In part, this is related to the affinity of each of these category of drugs to the muscarinic receptor as an antagonist. And this particular study that was published in the Archives of Internal Medicine really looked at the agents in the left-hand column, or 3-point agents, being the strongest antimuscarinic or anticholinergic that are more problematic probably in mental status change. And here we see some of the tricyclic antidepressants like amitriptyline, atropine, certainly benztropine, but also some of the older antihistamines, chlorpheniramine, which really is not used all that much, but occasionally used in some of the older cough and cold preparations. Dicyclamine, which is actually used in sleep aids, and diphenhydramine or Benadryl, and I think we look at that being highly antimuscarinic or anticholinergic. Finally, hydroxyzine or Atarax is problematic, imipramine being problematic, meclizine, which we use for Meniere's disease, And some of the agents that we see used as antimuscarinics in genitourinary conditions like oxybutynin. So important to sort of differentiate these. Then there are the sort of the 2-point and the 1-point agents that are antimuscarinic as well that contribute to some of the peripheral effects we already talk about throughout the year, dry mouth, dry eyes, constipation, but the central nervous system effects of dizziness, falls risk, but also particularly confusion. We look also at multiple other studies that look at the drug burden index in functional status for older people. And typically we find that the antimuscarinics and the sedative drugs is associated functionally with poor community function in people, older folks who particularly dwell in the community. And so they may have started on therapy intended to be short-term or earlier in their life that got continued, and it's maybe time to peel away some of these medicines. There's also a concern for the risk for antimuscarinics in subsets of populations. And here's a study that looked at the cognitive impairment in an African American population. What they found is that antimuscarinics or anticholinergics were associated with an increased risk for cognitive impairment pretty significantly. It reached a p-value of 0.02, at least in this analysis. And they also correlated if they had certain genetic markers. The APOE allele is particularly contributory or associated with a risk for responding or having a change in mental status, particularly delirium type condition, if they have that genetic marker. Also, another study that looked at women with mild cognitive impairment and their concurrent use of antimuscarinics was higher. Here's a study that looked at the antimuscarinic users versus non-users and their differences in cognitive impairment again, and seeing some dulling or delayed response there in this analysis. So those studies were helpful. There's one study that didn't demonstrate risk. I'll share that with you here. This was community-dwelling older men, not associated with cognitive impairment with the use of any particular agents particularly. But I will tell you that this study was fairly small, and so it may not have been powered enough to demonstrate adequately that risk. So in summary, what might we be able to conclude here? Well, probably anticholinergics are a likely partial explanation in some patients for a change in mental status, and we may be able to stratify who are at higher risk for antimuscarinic changes in mental status and antimuscarinic associated changes in mental status. There's probably a genetic influence. Females might be at higher risk, older age, agents that are stronger antimuscarinic, larger doses of those agents, or longer exposures. All of those are probably correlated with a higher risk with antimuscarinics. So, for example, if you had a patient who didn't have many of these risk factors and there was a good indication for you using diphenhydramine, for example, short-term use, then that might make sense to consider the risk and benefit of that, stratifying to the patient that this patient is probably going to be able to tolerate Benadryl. And the other thing to consider is if you had a good, compelling indication for using diphenhydramine and a serious allergic reaction, this change of mental status is controllable from the point of view that once they're completed their course of Benadryl, or you can stop the Benadryl if there is a change in mental status. Each of these are sort of weighed the risk and the benefit. Anticonvulsants are probably also associated with changes in mental status in some folks. As we think of, these agents have a lot of cognitive impairment with them, some more than others. And so we look at that. And many times the patients who are starting on these anticonvulsants aren't on them for a seizure risk, but they're on them instead for pain management, neuropathic pain, or maybe some other concurrent indication, maybe a mood disorder. And so we want to make sure that depending on the agents that we're using, can we come up with an alternative? Is the drug dosed for renal or hepatic function? Is there something else that's an interaction that we haven't paid attention to that elevated the anticonvulsant level to a degree that's contributing to whatever the problem is? So some of these are controllable events. Some of the antihypertensives associated with changes in mental status, particularly those that are fat-soluble, that cross the blood-brain barrier, particularly the beta blockers, for example, are true, or the adrenergic, some of the adrenergic agents like clonidine or methyl-dopa can sometimes cause changes in mental status as well. As we allude to in the neurology Parkinson block, the antimuscarinics and the dopaminergic drugs are associated with a fair amount of change in mental status, maybe agitation, particularly with the dopaminergic drugs. And we want to just be clear that we're titrating the beneficial effects of managing the patient's Parkinsonian symptoms with the potential of adverse effects with each of these agents. And that's sort of a tightrope to walk with a number of patients. In the management of psychosis associated with Parkinson's disease, there's a lot of studies that are out there, but it's clear that about a quarter of the patients who have Parkinson's will probably develop some degree of hallucinations and psychosis that can be problematic. And the dilemma here, and we talk about this in the neuro block as well, is to weigh the risk and the benefit of how effective is that anti-Parkinsonian therapy. Have we titrated appropriately? Can we adjust the dose or give a different delivery system of their products so that we have more even levels today and lower risk for psychosis? And then when we're picking an antipsychotic, the atypical antipsychotics, the one I see probably used the most often would be quetiapine or Seroquel. As far as benzodiazepines, they're notorious for causing memory impairment. Think about when we give benzodiazepines as part of procedural sedation. Someone's going in for a colonoscopy, for example. It's pretty common to use midazolam, a short-acting benzo, certainly to sedate the patient so the patient's not aware of what's happening, but also for the benefit of impairing memory while they were unconscious, or while they were under the influence of the benzodiazepine. Benzos also, though, do that no matter what the benzodiazepine is, and many patients who are on benzodiazepines for anxiety will also talk about memory impairment, both short and longer term, but typically short term. Benzos also associated with oversedation and falls risks as well. And benzos, we used to use these a lot in older patients when we thought they were having delirium. In fact, we find benzos contribute to patients missing cues in their environment that help orient them. And actually, because of that, benzos actually make delirium often worse. And so, at least in our ICU setting, and I think in most ICU settings, we really look to where delirium can happen pretty frequently, we look to avoid benzodiazepines when we can. There is a correlation genetically in patients who may or may not be at higher risk for memory impairment with the benzodiazepine. And so just to recognize that while we don't test for this genetic variation, we do see that there's a correlation genetically in who is at risk for memory impairment or not with benzodiazepines. So basically similar to what we saw with antimuscarinics, same kinds of issues are seen with predisposing risks for memory impairment with benzodiazepines as well. And the risk for patients transitioning into delirium is greater with an ongoing benzo dose, particularly a higher dose of benzodiazepine. So we typically, again, try to avoid benzos in patients who are at risk for delirium. Another drug, interesting, I just pulled this out to be more sort of interest, but patients may have heard this over time, is that even the statin drugs are associated with some reports of memory impairment or forgetfulness. How true this is probably not clear. Keep in mind that we have millions and millions of patients on statins, and so by default, some of those patients concurrently who have memory impairment that they notice when they start the statin or they've been on the statin for a little while, they may notice it worsening. However, because some of the reports see improvement once they stop the statin, Is it the statin or is it something else? It's hard to know. And because the statins interact with other medicines, it's hard to know if it's the interaction versus the actual drug itself either. But in any event, just be aware of that and weighing the risk and the benefit of statin use in the patient who's in front of you. Other drugs that are associated with changes in mental status, as we've alluded to throughout the we'll allude to some of these criteria here and again in geriatrics when we cover geriatrics in the curriculum as well. But there are a number of published guidelines that look at avoiding drugs, particularly in older patients. And these criteria aren't specific just for changes in mental status, but what I'll try to do is pull out in these criteria what the guidelines say about changes in mental status when the person is under the influence of those particular drugs. First are the Beers criteria that have been around for a couple of decades, and last revision was in 2015. We'll also talk about the START and the STOP criteria briefly as well. So the Beers criteria, latest update that is available is 2015. It's expert opinion, supported by systematic review of what's published in literature and a grading of evidence. And then they categorize the higher risk agents in a couple of different ways. Okay, let's look at some of the Beers criteria as it relates to potentially inappropriate medication use for older patients. And what we'll see here, the ones that are related to mental status changes include the anticholinergics and the antimuscarinics, as well as a few of the other agents, including the antiparkinsonian agents that are listed here, and also the antispasmodics that include a lot of antimuscarinics associated with them. Each of those, as we discussed earlier, the antimuscarinic properties contribute significantly to changes in mental status. Other things that we worry about are the particular drugs we use in the autonomic nervous system, particularly the central alpha blockers that have some central nervous system impairment for a number of patients. We also find sometimes digoxin is problematic as it relates to central nervous system changes. Certainly, the drugs we use in mental health can actually have adverse effects, particularly the antidepressants, particularly those that are highly anticholinergic or highly sedating, are potentially problematic from the point of view of changes in mental status. The antipsychotics, particularly if they cause akathisia, motor restlessness, gets interpreted or misinterpreted as a delirium. The barbiturates, which we rarely use anymore, certainly change in mental status is expected. The benzos, as we talked about, impairment in memory as well as sedation. Both the short and long-acting benzodiazepines. And also the agents we use for insomnia also can have a lingering effect or change resulting in memory impairment. Some of the other therapies that are listed here aren't a major issue, with the exception on the bottom of the page of the opioids. And all of the opioids, we consider the risk and the benefit of giving the opioid. Keep in mind that the opioids themselves certainly can cause changes in mental status and actually have some psychomimetic effects that are negative for patients. But uncontrolled pain also can be distressing to patients and be a concern as well. And so you're weighing the risk and the benefit of that. And if using opioids, you certainly also want to be thinking about all the other things you think about with opioids, but particularly paying attention to bowel function, and that if a patient's impacted, the discomfort and distress that causes patients contributes to mental status as well. We see other organ systems that are affected by drugs, but really when we talk about central nervous system effects, the skeletal muscle relaxants, about 2/3 of the way down the page, are problematic in that most of the skeletal muscle relaxants probably don't have a tremendous amount of benefit associated with them, and they certainly are associated with high risks for cognitive impairment. Okay, the next sets of tables look at certain disease states where there is a problem associated with certain drugs with patients with that pre-existing condition. And so let's go down the bottom of the page for delirium here. Certainly the drugs we've talked about already with delirium, the cholinergics, the antipsychotics, the benzos, uh, uh, even corticosteroids, and sometimes the antimuscarinic properties associated with some of the older H2 blockers, particularly cimetidine, which we rarely use anymore, it can be problematic. Also, for dementias, antimuscarinics are problematic, and so you want to be aware of that. Patients who have changes in mental status related to insomnia and lack of sleep and the sleep deprivation that changes mental status, we want to see if there are any drugs that can do that. And certainly the stimulants can do that, the oral decongestants can do that, and agents like theophylline and caffeine also associated with that. And in addition, in patients who have Parkinson's, certainly we know that their condition can get worse related to that, and that all the changes in those meds also can affect their cognitive status, as we've alluded to. The fourth table here are drugs that list drugs that are potentially inappropriate, that the Beers doesn't recommend not using them, but recommends caution when they're using them. And there's a long list of medicines here, but I won't really dwell too much on this table. The fifth table also looks at important non-anti-infective drug-drug interactions that we consider. So keep in mind that the drug-drug interactions themselves could be additive and worsening cognitive function, particularly the second one listed here, the antimuscarinics and drugs that are additively antimuscarinic, but also a lot of these medicines have central nervous system effects that can be additive or synergistic. The other sixth table here looks at drugs that should be avoided or have their dose reduced in older patients, and some of these have central nervous system effects, particularly the middle of the chart here that looks at duloxetine, gabapentin, and the like. And the Beers also, like we saw in that earlier study, listed drugs with some strong anticholinergic properties, particularly the antihistamines, the antiparkinsonian drugs, the skeletal muscle relaxants, the antidepressants, the antipsychotics, and some of the antiarrhythmics as well. There are also, just for the sake of completeness, there are some medicines that were added or removed from the earlier Beers list. They're listed here, but for the sake of this discussion, not as critical, as well as what we just talked about in Table 8. And again, more medicines added or removed, and these are meds that have been added more recently. The Canadian approach that's been around for a couple of decades now is similar to what we see with the Beers approach. And this hasn't been updated recently, but I think there are some overriding principles that help to summarize the themes we've already talked about here in the Canadian approach that's listed in this article. The overall key recommendations they recommend are themes we've already heard. Avoid long-acting, long half-life benzos, and in fact, we try to avoid benzos entirely if a patient's at risk for delirium. We look at avoiding the antimuscarinic tricyclic antidepressants, barbiturates, which we don't really use in clinical practice anymore anyway. MAO inhibitors, if the patient's on an SSRI, avoid meperidine, won't use that much. Avoiding anticholinergics and avoid skeletal muscle relaxants. Finally, the start and the stop approaches. These have been around for a number of couple of decades anyway, and they've been revised periodically. These are from originally published in 2007, 2008, and has undergone some revision in the last decade or so. The second set of updated criteria, version 2, were published in 2015. Here are some of the summaries in the STOP criteria, and I've highlighted or put in red box those that affect the central nervous system. And you'll see as you look through these at your leisure, these themes are similar to what we saw in the Beers criteria and the Canadian approach as well. Nothing really highlighted on this page as it relates to delirium or change in mental status. Here we have, as far as analgesics go, focusing on long-term opioids and looking at avoiding long-term opioids to the extent that we can in older patients. Now, you'll find that this actually dovetails well with our general approach of avoiding long-term opioids in anyone but patients who we've ruled out everything else from managing their chronic pain, or certainly we don't avoid using opioids in patients with malignant conditions, particularly cancers. Another chart, but nothing here particularly related to delirium or mental status change from the STOP criteria. In one of the last sections in this block, let's talk about now some of the treatments we have and the management we have for Alzheimer's type dementia, keeping in mind that we still don't know as much about Alzheimer's as we'd like. Typically, we see a genetic predisposition. Probably it's related in addition to that plus environment. We see an accumulation of beta amyloid. There's an inflammatory component, and there appears to be a neurotransmitter deficiency as it relates to acetylcholine in particular. So there are a number of ways to assess mental status in Alzheimer's, and there's a few different cognitive approaches that are listed in this slide. I'm not going to go through that in depth. I'm hoping that in the curriculum somewhere you've got access to or can look at some of these assessments. But when you get to your rotation, certainly where you're dealing with patients who have a risk for changes in mental status, particularly Alzheimer's type dementias, you'll find that one of these tools or a couple of these different tools might be used in that clinical setting. The comparison of memory impairment and dementia from Alzheimer's is listed here. I won't go into again, repeated as we talked about earlier in reversible versus non-reversible causes, but we really do our best to identify those reversible causes first. And then the stages of Alzheimer's, typically mini mental status evaluation score based from mild, moderate, and severe. And what you typically see for examples of cognitive loss and functional loss in each of these layers of or degrees of Alzheimer's type dementia. In assessing dementia, typically, again, a couple of scales that are used are listed here. I encourage you to go to the video posted online for some discussion about how we assess and disclose the diagnosis of Alzheimer's. It's really beyond the scope of pharmacotherapeutics per se, but it's a very sensitive issue for patients, and you need to do that in a way that is ethically and professionally appropriate. So as far as the treatment of Alzheimer's, really what we'd love to do is to stop Alzheimer's in its track, to maintain cognition and stop the progression of decline. Typically what you can't really stop, but some of the agents early on, if they're initiated early enough, may slow the progression of Alzheimer's dementia and maintain function for as long as possible. There's a lot of non-pharmacologic approaches that are used in Alzheimer's type dementia, and this is really directed toward the caregiver who really has a huge burden with caring for patients with dementia. A lot of education, a lot of support, and a lot of respite is needed really for these folks. We also can find ways that we reduce environmental triggers for patients, and we can optimize the management of comorbid conditions that can help as well. But the environmental triggers, typically what we usually do is to make sure there are enough things that are orienting the patient to where they are and have familiarity associated with them. What you'll find that many patients who have dementias or concurrent delirium with a dementia often are feeling quite disoriented. So the kind of environmental things we want to make sure of is that does a patient have a hearing aid? If so, do they have it in place? Do they wear glasses? If so, are they available to them for them to wear? Do we have orientation for calendars and clocks? Is there adequate lighting? Is the layout of their living situation in such a way that it does not trigger a confusion for them of where they are, like they don't feel like they're in a maze? And sometimes things as simple as floor tiles, the layout of flooring, for example, or the placement of furniture, that if it feels like a maze for the patient and it's unfamiliar, that can contribute to agitation in someone who has some degree of dementia. The agents we use are listed here, and they really fall into really two groups. The cholinesterase inhibitors have been around probably for the longest period of time. Donepezil, rivastigmine, or galantamine are the three agents that we see most often used, and their properties and concerns are listed here in this slide. The other agent that's probably used pretty commonly and sometimes in combination is memantine. It's a glutamic therapy that will be effective in moderate to severe dementia, where we'll start the cholinesterase inhibitors from mild to moderate. And sometimes we'll continue those agents through moderate and severe by layering on memantine to therapy. The symptoms of Alzheimer's, as we alluded to earlier, mild, moderate, severe. This graphic is a little more specific than the earlier one for layering symptoms based on where we see mild and worsening symptoms as time goes on. So initiating therapy with Alzheimer's, this is more or less consensus guidelines from the American College of Physicians and the American Academy of Family Physicians. And the recommendations are for patients with mild to moderate. Their recommendation for the most part is to talk with the family and the person involved and going over the risks and the benefits associated with cholinesterase inhibitor and considering adding it. There also is, there are, over time you want to manage expectations with patients. There are significant differences in the research that's been published, and so you want to not oversell the benefit of the cholinesterase inhibitors. A few patients, or very few patients, may actually have improvement, but most of the time what these agents are going to do is they're just going to slow the decline. So you don't want to oversell it and have an expectation that patients are all of a sudden going to get better. What you really have to sort of share is that for the most part, what these agents will do is help slow the progression over time, so you'll have you'll maintain function for as long as you can. There's not any clear evidence that one cholinesterase inhibitor is better than another, but we're going to titrate those accordingly. And then we see the issues from memantine. Again, not really superb data, just really slowing progression over time for the most part. And in combination or alone, we weigh the risks and the benefits associated with these therapies. And there may come a point in time where the benefits are really minimal with these therapies, and the patient may be a candidate for actually coming off of them. The duration of therapy in Alzheimer's is looking at, we expect a decline without treatment of about 4 points on a mini-mental status per year. So we evaluate that every 3 to 6 months. And we'll look at if folks are better than that 4 point per year decline, we probably would be an argument to continue therapy. If the folks are on a high dose, we recommend a taper if we're going to stop or reduce therapy. And you want to keep in mind that when we stop therapy, there may actually be a rebound agitation that happens, and so titrating is really considered appropriate to do. The actual response to cholinesterase inhibitors, typically we see just modest, if anything, with these agents. Same is true for memantine, that we might see a subtle change, but really not a major one, and so don't oversell the benefit associated with these therapies. The behavioral symptoms of dementia are also a major complication we see with patients with dementia. And if you're working with patients who are older, either living at home with caregivers who are burning out, or you're working in a long-term care setting of some kind, assisted living or a long-term care facility, we see that this is a very frequent scenario that the clinician is asked to sort of help manage. More than half of the folks who have dementia will have significant behavioral or psychological symptoms, and we try to look at what those symptoms are, quantify and qualify them, whether they're psychosis or they're agitation. And you want to pinpoint, is the psychosis delusional? Is it paranoid in nature? Is it hallucination? For agitation, are they combative and aggressive? Do they hurting themselves or others? Is it hyperactivity that's wandering or pacing that could be redirected? Is it hypervocalization? Is it disinhibition? What is the nature of those type of symptoms patients are seeing? The measurements of behavioral symptoms, there's a couple of different scales that can be used. They're listed here. That we don't always use scale. Often what patients will present with is a couple of specific behaviors that are problematic, and the clinician is going to work with the healthcare team, the caregivers, and even the patient themselves to try to really manage those target behaviors or symptoms so they're more tolerable. The management, what you want to first rule out is there something you can do about it? Is the behavior symptom triggered because of pain or constipation, hunger, dehydration, depression, fear, anxiety, all of these things? And you can do something about all of them. And so you really get to the root cause of why the behavior is happening. And before you layer on drugs that affect mental status, you really instead are first addressing the root cause of what the behavior problem might be. The classic 5 R's that are done in managing behavior symptoms are to reassess, to reconsider, to rechannel a patient's energy somewhere else, or redirect them or remove them from that environment, and to reassure them. Now, some of the things that we see that are triggers for patients are to redirect patients in a way that really sort of circumvents the issue that the patient has. And so sometimes that is to redirect them. So we don't necessarily challenge a statement that a patient has. It may be true or not true. That's their reality. But I'll share with you, I remember a patient for whom this was in the early 1980s when I worked part-time in a long-term care wing of a hospital. And a couple of the new caregivers had a patient with severe dementia, and the patient kept asking for her wife, and they kept the caregiver, who was naive to this practice, had kept reassuring the patient that no, his wife had died 3 years earlier. And every time that he heard that, he heard it for the first time, and he went through incredible mourning associated with that. And so we don't really challenge what the patient says. You just redirect, you change the conversation. You don't try to challenge them to what reality is if that reality is not going to benefit anybody and is going to make the patient more agitated. So that redirection is a common scenario done. And a lot of the management we do really is non-drug management or management of an underlying aggravating consideration. So the non-pharmacologic interventions we talked about, educating caregivers about how to intervene with patients, correct their underlying factors or reasons. Do they need to toilet? Do they need to change mealtime? Do you need to adjust the environment for the patient's wake-sleep cycle, which might not be the same as other people in that living environment? Are there pet therapy, music therapy, other kinds of things that can help? What orientation aids can help in the room? Can there be a whiteboard? Can there be a clock? Can there be, hearing aid and or glasses? Having a routine available that meets the need for that patient. And then environmentally improving lighting, making sure the environment is safe, that there's an appropriate amount of sensory stimulation in there, and then allow for personal space for that patient. The kinds of symptoms we'll see in patients who have behavioral complications, psychological symptoms associated with Alzheimer's include anxiety, apathy, depression, insomnia, wandering, paranoia, and aggression. In each of these, we want to look first at the non-drug interventions. When possible, in the right-hand column, there's a list of some things that might be considerations. For example, for anxiety, you're going to look at the non-benzodiazepine choices whenever you can, including either buspirone or maybe an SSRI or SNRI for anxiety. You may look at, for patients who have apathy, whether cholinesterase inhibitors are helpful. For depression and SSRI or mirtazapine, sometimes a little more sedating agent may be helpful. For insomnia, just plain old melatonin may be helpful. For paranoia, most often the agent I see used is a low dose of quetiapine or Seroquel. It's a little more sedating. It's pretty well tolerated. It's the agent I see probably used of antipsychotics most frequently. And for aggression, there's not a lot of really good data for drug therapy for that. A couple listed here, but not really with great data. The cholinesterase inhibitors themselves, the atypical antipsychotics are typically the FDA has really warned against using them because of an increase in mortality risk associated with them. We try to save them for last resort, and I will say that the agent we use most often when we use them, and we've tried other environmental things, is low-dose quetiapine. Other things that are used, antidepressants, as we alluded to, particularly when we think about anxiety or concurrent depression with patients. There's some modest data for valproic acid or Tegretol, but the data is not really strong for behavioral management. Memantine, like the cholinesterase inhibitors, may help overall. Benzos we generally avoid. Okay, in this block, here are some drugs that we expect that you have familiarity with.